Okay, that's mostly the physical then. And I assume that other members of the team assess psychological pain, spiritual pain, or emotional. Do you have something to say about that?
Yeah, it's an excellent point. Each person's experience of pain is individual and it's unique, and one person may have the same type of physical stimulation that has caused the pain, and their pain may be described as a 3, and the other person may describe it as an 8 or a 9. And the reason, as we understand that, is that what a person brings to that pain experience, their as far as their previous experience of pain, their overall physical, mental, emotional health influences that patient's assessment of pain. And if a patient has a lot of this other total pain concept, if they have a lot of emotional pain or spiritual pain or relationship pain, then their experience of physical pain will be even worse. So we rely on the team members. And as you know, the hospice team it's not just the physician or the nurse or the aide, but it's the chaplains, the bereavement team, the social workers, volunteers, who all together try to assess the patient's unique pain experience of whatever type of pain is, and then to develop approach and to treat that pain.
And obviously, if someone is physically hurting, you can't talk about spiritual or emotional things. Just as you were saying, their emotional or their spiritual may actually be contributing to the physical, but there's a kind of a hierarchy of needs that we address the physical pain first. If someone is hurting, we try to deal with their pain first, and then we can hopefully bring them to a level of comfort that they can have the energy to deal with some of these other things.
Yeah, absolutely.
Yeah. So what are some of the methods that you would, let's separate physical pain, remembering that we're talking to a lay audience that won't know a lot of the medical terminology, but what are some of the methods that you have for addressing these various kinds of pain?
Well, from a physician standpoint, the physical pain will always look at non-pharmacologic treatment, non-medication treatment. We'll do the things that you've probably have had in your own home, treating yourself when you've experienced pain, whether it be ice or heat or comfortable pillows,
Good bed.
Good comfortable bed, a mother's kiss on the forehead, soothing sounds, music, some distractions. Those are always important regardless of the type of pain. And then there's pharmacologic or medications that we also use. And one philosophy, again, we use in treating patients with pain, typically in hospice, we treat them around the clock with their pain medication rather than as needed. It is believed and shown that it's easier to treat pain before it becomes so intense and severe. So we don't like to catch up. We like to stay ahead, get them on a scheduled medication, and then use as needed medications if they still have pain. There's a scale, we have many medications to choose from, and it could be as simple as Tylenol and Advil to, on the other extreme, it could be morphine and Dilaudid. Many of us think of treating pain with oral medications, but not only is there a number of different medications we could use orally, but there's a number of different methods of delivery. Some people can't swallow pain medication, so we may use sublingual medication, putting it under the tongue. Some people can't even do that, so we may use a patch, or we may use a gel where we wipe it on or rub it, apply it to their wrist. Sometimes we need to use rectal medications, which also are a very effective way of treating pain. And progressing further, there's a way to use subcutaneous medications right under the skin, where we put a needle under the skin and and deliver medications that way. We can also use intravenous pain medication, and for some real refractory cases, we can even do nerve blocks, spinal blocks, where in a surgical type procedure we inject pain medication into the nerve that is associated with the pain. Often we use anesthesiologists to help us with
For
that.
hospice situations, you primarily stop. How far on that scale would you go? What would be the most extreme form of pain management?
Well, we like to use oral initially and always is the most comfortable and easiest way, but it's not always possible. We'll progress through all the different types of medications. In some patients, we will even do the surgical interventions with nerve blocks. However, I've found in my experience that we have so many different medications that with a team approach, we rarely have to go to that extreme.
Adjusting the medications and the dosages of that to
Yes.
reach a level of comfort.
Absolutely. We assess the type of pain, we treat, and then we reassess, modify our treatment, and continue that process. And the intrinsic to one of the goals of hospice is to keep the patient at home and treat them in their home, keep them from going to the emergency room, keep them from getting admitted to the hospital. Often the hospice patients, if they're often the reason why patients go to the ER or hospital is because of pain, but with our team of expertise, our team on hospice, we come to them in their home and we treat them there, and rarely are we unsuccessful in minimizing their pain.
I know you've talked about staying ahead of the pain. I also know from having listened to some of these discussions that I do understand that you try to build up dosages. You do not try to go too far too quickly.
Yeah, absolutely, especially in the older population. The older population metabolizes the medicines different than a younger person would. However, the older population still has considerable pain, so we don't not treat them with some of the strong medications, but we have a kind of an adage where we say, go slow, go low, but go. Mm-hmm. So treat, start slow, and just keep going.
Mm-hmm.